Thank you, Dr. Angzitek, for the comprehensive review of the current analgesia for TKR surgery. I think Dr. Zitek just said that you have committed a big sin if you still use epidural analgesia. So, okay, so next speaker is Dr. Iskandar Khalid. I think I don't have to introduce, I mean he has a very impressive CV. So he's famous among the trainees for all the primary, he's a primary tutor and he gives a good lecture in the primary staff. He graduated from the International Medical, IMU, and I think his postgraduate is from UKM, and he's also a budding, I would say, a budding regionalist, and he's also active in a lot of workshops. So he's very enthusiastic person, I would say. So without further ado, I invite Dr. Iskandar to deliver his speech.
Assalamualaikum and good morning. Thank you so much for that kind introduction, Dr. Ame, and sorry for the delay. So let's just get started. I was given this topic, RA in the era of ERAS, so I'll get straight into it. So I do not have any conflict of interest to declare. And before I begin, I just want to thank the organizing committee of the Wilayah and Selangor Anesthetic Conference, the Hospital Ampang Society of Anesthesia and Intensive Care, Dr. Carol, Dr. Sani and team for first inviting me and of course organizing this lovely conference. So I work here, Hospital Chancellor Tuanku Muhri, so HCTM, what used to be called HUKM. And where I like to spend my time is in the regional corner. So we do quite a number of blocks, about 50 to 60 blocks a month, not as much as maybe HKL, but I think a decent amount. So we do perform a lot of blocks, we do see many cases. So focusing on the topic for today, RA in the era of ERAS. So there's a lot of RA in there, 3 times the word RA appears. So I was thinking, how do I go about this? First, maybe I should explain a little bit what does ERAS mean. So ERAS stands for Enhanced Recovery After Surgery. So only when doing this, preparing for this talk, I realized that ERAS has a trademark. I didn't know that. Apparently ERAS is trademarked by the ERAS Society, so you can't just simply use it. So what it means is it's an evidence-based, it's integrated, it's multidisciplinary, multimodal, perioperative care pathway and designed to achieve early recovery for patients undergoing major surgery. So every word there has a meaning. So this is Dr. Henrik Kelle. So he is a Prof Emeritus from the University of Copenhagen. He was a colorectal surgeon. So in about 1990s, 1997, he had this epiphany. Why is it when they do colorectal surgery, why do the patients go home after 10 days, after 2 weeks? Why? Can't the patients go home after 2 to 3 days? So this gentleman, this professor, was essentially the father of ERAS. So he and a group of his colleagues got together and later wrote down this, the first guideline was for colonic surgery. And basically they challenged many traditional surgical practices at the time. Everyone were forced to go through bed rest. They had drains inside. They were told not to move and all. They had the NG tubes in for a week. So all these things which did not have an evidence base were thrown aside, okay, were abandoned. So this was first started in colorectal surgery, and what their goals were, they wanted to make the patient recover faster. They wanted less complications and a shorter length of stay. And of course, they wanted to improve value by reducing costs and improving the quality of the practice. So this was quickly adopted. Everyone started copying him. So not just in colorectal, people started doing in other subspecialties. And now it's regarded as the expected standard of care. And the ERAS Society was formally formed in 2010. So what are the key components of ERAS? There are many components, you might have heard of them before, mostly divided to pre-op, intra-op, and post-op. But today I'm mostly going to focus on this, the role of regional anesthesia and multimodal anesthesia in ERAS pathways. So this was a systematic review by Nicholson and team. This is going to show you why ERAS is so helpful, why is it so important. So they did this review, and then they looked at, the first thing they looked at was complication rates. As you can see, it's a bit blur, but you can see from the forest plot there, there was a significant reduction in complication rates when the patients went through an ERAS pathway compared to when they didn't. And this was another systematic review of meta-analysis, more recently, just published in August 2023 in the Journal of Cancer. And they again compared patients, looking at patients who went through ERAS pathways, those who didn't go through ERAS pathways. So what did they find? So first of all, you can see that in terms of costs, you save a lot of money when you use ERAS. So, sorry, what I wanted to show was it doesn't matter which country. So those some studies in North America, some studies in Europe, and some studies in East Asia all showed the same thing. You save money when patients go through a ERAS pathway. And this one is looking at the, the length of stay. So again, same thing. North America at the top, Europe in the middle, Asia at the bottom. It's quite significant, between 2 to 4 days shorter if the patients go through an ERAS pathway. Again, you can see here again, this is in a hospital. So before the ERAS was implemented, patients stayed, colorectal surgery patients stayed for about 5 to 6 days. After they started ERAS, they could be discharged after about 3 days. So you save about 2 days. So you can imagine how much money is saved, how much time is saved, and so on. And most importantly, this study came out in January this year. It was interesting because it showed a mortality benefit when patients go through an ERAS pathway. So as we know in our practice, not many things are proven to reduce mortality, but they found this. So they looked at 9,000 patients and they showed that it doesn't matter, short-term mortality, long-term mortality, both was reduced when patients went through ERP, Enhanced Recovery Protocol. They also stayed shorter in hospital and there was no difference readmission. So you're discharging patients faster, but they're not coming back. That's what we want to know, right? We don't want to prematurely discharge patients. So this was a very important study released this year. And this is just to show another summary, Dong and team. So what they showed was in different types of surgery, you save a bunch of money when patients go through an ERAS pathway because, you know, it's not just a patient. At the end of the day, the healthcare system has to benefit as well. So this is something which can be done. And in summary, what we have found is when you use an ERAS protocol, patients stay in hospital for a shorter time, you save money, they recover faster, they have less peri-op mortality, less post-op complications, reduced risk for readmissions, and the patients are happier. Of course, they spend less, no one wants to spend time in hospital. They don't take it personally, but patients want to go home as fast as possible. So they're happier when they go through an ERAS pathway and they go home. So I've answered the ERAS part of this question. Now let's look at the RA part. So what is the role of regional anesthesia in ERAS? So pretty much how regional anesthesia is in anything else. Okay, it provides effective, multimodal, opioid-sparing analgesia. You can prevent post-op nausea, vomiting. You can avoid GA. You can avoid neuromuscular blocking agents. So every single one of these things are very desirable when you want a patient to go through an ERAS pathway. So as we know now, there's a paradigm shift when you manage acute pain. So in the older days, the opioids were the bottom of this food or pain pyramid, and you have regional anesthesia somewhere at the top. So most patients receive opioids. But now this is what we want to do now. Basically, everyone gets PCM, everyone gets NSAIDs if there are no contraindications, and ideally everyone should get regional anesthesia. At the same time, in the US and Canada, there's something called the opioid crisis. I'm sure many of you are aware. So an overuse and oversupply and easy availability of opioids has led to a rise in opioid-related deaths. So Opioids, I don't need to say have a lot of problems, although sometimes you still need opioids, strong opioids for major surgery, but we need to try to limit their use. So to answer the question of RA in our ERAS, I had to find something to back up whatever I was trying to say today. So first thing is the ERAS Society itself. So they came up with guidelines for 15 specialties. And I wrote 14 there. I couldn't find what the 15th one was, but they wrote there 15 specialties. So I found 14 guidelines. You can see pretty much most types of surgery is covered here. And just to fill in the blanks, I also looked at the prospect guidelines. So Dr. Zitek mentioned one of the guidelines for total knee replacement. So the good thing about prospect guidelines is it looks at, is procedure specific. So it treats each type of procedure uniquely. So you know that different surgical procedures have diverse pain characteristics. They're all different. There are different consequences of inadequate pain relief when you do a thoracotomy or you do a laparotomy or you do some hand surgery. Inadequate pain control will have a different implication, right? And of course, each intervention is carefully evaluated. So they do a very rigorous process known as the Delphi method. It's basically a bunch of experts arguing and then using the latest and highest quality evidence to come up with the recommendations. So first of all, let's look at RA in ERAS, orthopedics. So what the ERAS Society has come up with is 3 guidelines. So I put a star there because they combine the THA and TKA guidelines into one. And then there is a lumbar spinal fusion guideline, and there's a star there because Prospect also has a similar guideline. But what ERAS Society doesn't have is anything about the upper limb. So Prospect has that for shoulder surgery. So looking at THA, what is the recommendation? So the use of GA versus central nexus block, basically no difference. It's fine. These are interventions which are not recommended. So spinal opioids are not recommended for routine use. Epidural anesthesia is not recommended for routine use. So I know a lot of us still practice a lot of CSE in our THA and TKR, but the idea of ERAS is for the patients to go home fast. You don't want urinary retention, you don't want them to be stuck to the bed and so on, you want them mobilizing ASAP. So this is something which is no longer recommended by the ERAS Society. And at the bottom there are some nerve block techniques, but when compared with LIA, prolonged motor block may limit early and safe mobilization. So I feel like this guideline has some flaw here. They're referring mostly to those blocks which block the motor nerves, such as the femoral nerve block, the lumbar plexus block, and so on. Although we have a greater number of the specific blocks which only block sensory nerves, maybe because these blocks are quite new, so they don't have many studies yet available. So perhaps that's why they are not recommended yet. But what they do mention is a single short fascia lacca block is recommended, just a grade D though, due to its analgesic effects. And if the patient has received spinal anesthesia, you can consider morphine, but even the Prospect group couldn't really come with a consensus, so they had some conflict amongst themselves. So some of them favored IT morphine at a small dose, 0.1 mg, because the risk, serious side effects are quite uncommon. But at the same time, you can get pruritus, PONV, which defeats the purpose of ERAS. So that's why they couldn't really come up to a consensus here. These interventions so far are not recommended because there's just not enough evidence. So LSCN, QL, femoral nerve block, lumbar plexus block, epidural anesthesia. So what about TKAs, total knee arthroplasties? So remember ERAS Society, they use the same guideline for both, so it's the same thing. No difference, GA versus central nexus block, they're okay with both. And they say the same thing about nerve blocks, they don't recommend it routinely. A single shot adductor canal block, this is the Prospect guideline. So what Dr. Zitek has already covered, so a single shot adductor canal block is ideally combined with LIA technique. And we know that ACB preserves quartz function, unlike a femoral nerve block. So interventions that are not recommended are epidural, femoral nerve block because of the motor block, and sciatic nerve block also because of the motor block. IT morphine may be considered only if you can't do the other things. You can't do adductor canal block, you can't do LIA, then maybe you can consider IT morphine, but you have to expect the side effect which might delay the patient's recovery. So summary of these guidelines. So ERAS guidelines, they value interventions that promote early mobilization, which positively influences patient outcomes. That's why they don't like things like femoral nerve block. Motor sparing peripheral nerve blocks and LIA are increasingly used out of these guidelines. ERAS consensus falls short. So maybe this will change in the future since we have more specialized blocks now which only block the pain, the sensory nerves. So what about future directions for hip surgery? We have now what we call the PENG block. So this is what we call an ERAS friendly block, probably designed for ERAS because it blocks the sensory nerve supplying the hip capsule without doing any motor block. And we know that versus placebo, when you do a PENG block, you have better pain control, less opioid consumption, patients are happier. At the same time, you compare it to a femoral nerve block or fasciitis block, you get much lower incidence of post-op motor block, about 5 to 10%. It's not zero, but it's much less. So you don't have the issue of motor weakness. And you can see that here in this forest plot as well. Just 2 studies so far. See, everything is quite new for PENG block, but already they're showing that you don't get the issue of motor block. So just quickly, how does a PENG block look like? So you're just going to inject the LA, which is roughly where the head or the femur is, okay, at the acetabulum, and it's just going to work on the sensory nerves. It doesn't block the motor nerves. That's the beauty of this block. QL and ESP, some people do it for hip surgery, but evidence is just not strong yet for anyone to routinely recommend. Yeah. Okay, what about the knee surgery? So I think, again, Dr. Zeta has covered this in detail, so I'm just going to say the idea is the same. You want to block the distal sensory branches. You want motor-sparing analgesia, and we know that you can do femoral triangle and adductor canal blocks, which are not inferior to B. You preserve the function. There's something called the IPAC block as well, and there's some that adding it on can actually improve the analgesia further. So this was quite recently in the Facebook for UMMC. So I just want to share their achievement. They managed to do take daycare. So what they did was they used LIA, they used adductor canal block and spinal anesthesia, and the patients could. So you don't need to put an epidural catheter in and leave the patient stuck to the bed for 24 hours, stuck to the CBD for 24 hours. It's possible. So kudos to the UM team. And this one, Dr. Shah, I think Shaidan is here, took from his Facebook. So this was IHH adopting post-sparing regional anesthesia, such as adductor canal block for ACL surgery. So you can see that the recommended anesthesia technique is GA combined with ACB with or without LIA. And interestingly also, it's mentioned that utilizing spinal anesthesia with a short-acting agent such as prelocaine will be helpful. So this is something I'll cover a bit more later. So what I'm trying to say is, although the big guidelines are not routinely recommending these motor-sparing blocks yet, such as the ERAS guidelines, this is something people are already doing. They're moving towards that, okay? Incorporating these motor-sparing knee blocks into their pathways. Okay, next is about lumbar spinal fusion. So what is said is IT morphine versus placebo is good. In MIS spine surgery, it reduces pain score, it reduces opioid consumption. Epidural analgesia is something which can be done by the surgeon. They can put a catheter in themselves, and it's also quite beneficial. It's better versus PCA, but we don't really know what is the right regimen. And regional blocks have been described, but again, not much evidence. It's just because heterogeneity of techniques, these things are quite new, so there's not much papers to support ESP, QL, or TLIP blocks for all this. What about Prospect? So Prospect says that epidural analgesia with LA alone or combined with opioids is recommended, but they do suggest you use low concentrations of local anesthetics. And these are not recommended. So again, ESP, not enough evidence for Prospect to recommend. TLIP, not enough evidence. You do not want to give epidural intrathecal opioids ideally, because the idea is again enhanced recovery. So these are also not recommended. And what about upper limb surgery? So ERAS Society completely, forgot that to talk about upper limb surgery. So there's no guidelines for upper limb surgery from them. But the prospect does have a really good and robust guideline on rotator cuff repair surgery. So this is one of the guidelines where a block is very strongly recommended. So in this case, interscalene brachial plexus block, whether they do an open technique or whether they do a arthroscopic technique, the interscalene recommended, a continuous technique, and a single shot technique is also okay. But if you can do a continuous technique. As a grade B recommendation, they say that suprascapular nerve block with or without axillary nerve block is recommended as an alternative, but the interscalene should still be the first choice. And it does reduce pain score, but it does not seem to be better than the interscalene block. But I just want to put a word of caution about interscalene block, because as I'm sure many are aware, there is a significant risk of HDP, hemidiaphragmatic paralysis, because of phrenic nerve block. So it can go as high to 100%. To me, it's 100%. If I'm doing an interscalene block, I'm just going to assume 100%. And this causes a 27 to 30% reduction in pulmonary function. So most patients won't even realize anything. Some will have a subjective sensation of dyspnea. But some patients who are susceptible, and the obese, the elderly, those with lung disease, they are going to have respiratory distress. They are going to need NIV or intubation. And it's not surprising when you see how close the phrenic nerve is to where you're going to do interscalene block. You can see in the ultrasound image there, this is just millimeters difference. Okay, you can give 1 mil, it's still going to reach there. And this is how it looks like, of course. So this patient was before the block. After block, there was right hemidiaphragmatic paralysis, and the patient fortunately didn't require intubation. So you can reduce the HDP risk. Don't do the block, or use ultrasound guidance. It does reduce the risk, but it's not zero. You can try lower volumes, but again, it doesn't reduce the risk to zero, only to about 20%. You can then choose the phrenic nerve sparing blocks. So these are more selective blocks. Something like how we're going to block the more sensory nerves in the lower limb is the same thing. You're blocking the more distal branches of brachial plexus. So example is a superior trunk block, but I put a star there because the risk is not zero. It's still pretty high. Infraclavicular and costoclavicular also is not zero, but the risk is fairly low when you do a distal suprascapular or axillary nerve block. So what I'm trying to say is, if you have those kind of patients who are high risk, you want to put them in an ERAS pathway, you can still do it by using these more distal blocks. So just a brief mention of suprascapular and axillary nerve block. This is not axillary brachial plexus block, the one that you do at the axilla. This is the block of the axillary nerve itself. So these are the two nerves. And in meta-analysis, when you compare to interscalene block, you do get worse pain for the first 6 hours. So something you want to consider, maybe you want to add on some short-acting opioid. But from 8 hours onwards, they're equal to interscalene block. You don't get motor block because it's a very distal sensory block. You get lower risk of complications, Horner's syndrome and subjective dyspnea because of HDP. So it's good suprascapular nerve block. It can be done here in the supraclavicular fossa, something like not far from where you do a supraclavicular nerve block. You do not want large volumes because you're very close to the phrenic nerve, but there's still about 7% risk of HDP. And you can do it in the supraspinal fossa as well. This is the posterior approach, so the risk is much lower, about 2%. The axillary nerve block is done like this. So you just put the probe behind the humerus and you can block it there. Okay, right, moving on. So what about thoracic surgery? So the ERAS Society have come up with guidelines for thoracic surgery, cardiac surgery, and breast surgery. The prospect guidelines have come up with guidelines for VETs. So thoracic surgery for the ERAS Society, we know pain after thoracic surgery can be bad, so they strongly recommend regional anesthesia, but their first choice is still TEA, thoracic epidural analgesia. Okay, it's an old technique, useful technique, but not many people are very proficient at it. We know the risks are higher. You can get more hypotension, acute urinary retention, muscle weakness. A lot of patients now are on anticoagulants, so this is going to be a problem, so they can get hematomas. As an alternative, they do mention you can do a paravertebral block, which does have lower risk, but again, this is not a common block You usually need a certain level of expertise to perform the block. So it's not something which is routinely done. So the other thoracic wall blocks, the idea is just you're moving, is the same, just like the upper limb, the lower limb, you're just moving further away from the neuraxis. So you're moving down the intercostal nerve from the serratus anterior plane blocks, the PEX1 block, and so on. You're just getting more and more distal from the central neuraxis. This includes ESP, the SAPB. They are easier to perform. They're technically safer, technically less challenging to perform. They have less complications, but they're weaker analgesics. And there is evidence for continuous ESP and SAPB, but again, more evidence is needed in thoracotomy. So what about the prospect guidelines? They do mention paravertebral block as the first choice. So they no longer, unlike the ERAS Society, they do, TA can also be done, but this is only if you don't use a paravertebral block. But what is good is they have started accepting other techniques such as the ESPB, either with a single shot or a catheter. And the ESPB is also recommended because there are studies showing that it's effective versus sham block. So Prospect actually has ESPB in it. The serratus anterior plane block is a second choice after the ESPB. So now looking down, the things which are not recommended, intrapleural analgesia, intercostal nerve block. Again, thoracic epidural block is not first choice for Prospect. So cardiac surgery, ERAS Society had nothing regarding regional anesthesia, no mention, but Prospect did have. So Prospect actually recommends parasternal blocks, and they don't recommend epidural analgesia or IT opioids. So it's something you can do. Parasternal blocks, quite fairly simple to do. What about breast surgery? So ERAS Society, again, they don't have much on RA. They do mention women should receive multimolar analgesia to mitigate pain, of course. And a small mention about TAP blocks. If you take the flap from the abdomen, then there is a role, but they don't mention anything else about regional anesthesia. So thankfully, Prospect was a bit more helpful here. They do recommend paravertebral block as the first choice. Again, something which is not commonly done, but it's shown to have a lot of benefits. They do say you should consider a continuous paravertebral block if you do major breast surgery. And there is mention already of PEX block. Okay, if there is no axillary node dissection, or if paravertebral block is contraindicated, they do recommend a PEX block. And there is mention of serratus plane block, although the evidence is not supporting. So interventions which are not recommended, ESP and the TT transversus thoracic muscle plane block. Okay, now abdominal and pelvic surgery. So ERAS has a lot of guidelines here because it started in colorectal. So it migrated to nearby organs first. So esophagectomy, pancreaduodenectomy, liver surgery, bariatric surgery, colo, gynae, and cesarean section. The Prospect guidelines do have added mention on lap chole, open inguinal hernia repair, and prostatectomy. So let's look at ERAS Society in esophagectomy. TA is still considered the first choice, the gold standard. They do mention paravertebral blocks, but remember, you often might need to do this bilateral, depending on the type of incision which is given. What about Whipple surgery or pancreato-duodenectomy? So it's strongly recommended TA for an open technique instead of using an IV opiate. Instead of using PCA morphine or morphine infusion, you should still use a thoracic epidural analgesia because you have better GI function and you have less PPCs, pulmonary complications. For liver surgery, strong recommendation from ERAS for TA, and weak recommendation for, they do weakly recommend that you don't need RA techniques if it's a laparoscopic liver surgery. And there's a strong recommendation that TAP block can be done to supplement. So if patient has poor pain control despite the epidural, you can add on the TAP block. Prospect has more detail here. Again, TAA is the first choice, but they're quite progressive in the sense where they added on the bilateral oblique subcostal TAP blocks. So something you can do as a single shot or a catheter technique. And for lap chole, I think everyone expects this. The blocks are basically not really recommended for lap chole. So no role for TAP block or the oblique subcostal TAP block, there's OSTAP. And even other blocks, no blocks are recommended for lap chole. You don't need to block the patient for lap chole. So bariatric surgery, there's a weak recommendation that you can use RA if it's a laparotomy. So I've not seen an open bariatric surgery for some time. So probably in our current practice with laparoscopic techniques, again, there's no role for regional anesthesia. This is from Prospects. They also don't recommend TAP blocks anymore for lap sleeve gastrectomy. All right, so colorectal surgery is where ERAS first started. So they have a lot of, the guideline is the thickest of all. So they strongly recommend to avoid opioids and to use multimodal analgesia to combine it with neuraxial techniques or TAP blocks. They strongly recommend TEA, and they strongly recommend spinal anesthesia with low-dose opioids such as IT morphine. They also strongly recommend TAP blocks, which can also reduce the opioid consumption. What about Prospect? Prospect, again, they suggest continuous TEA. They do not suggest TAP block because there's not enough evidence there. So open inguinal hernia repair. So they recommend LIA, or you can use a block. You can do an ilioinguinal, iliohypogastric block, or you can do a TAP block. So this is a strong recommendation. Again, one of the few strong recommendations. Prostatectomy, TAP block is recommended as the first choice, whether it's a laparoscopic technique or robotic technique. If you do it bilaterally at the end, it lowers pain scores. So things which are not recommended, epidural caudal, TAP, or rectus sheath block. For gynae oncology surgery, again, nothing specific. It just says you want multimodal analgesia and you want to consider including a thoracic epidural and a TAP block. The Prospect had a bit more detail here. They just mentioned epidural analgesia can be considered, but as a reserve intervention. It shouldn't be the first choice because laparoscopic, you don't expect much pain. And TAP blocks are not recommended again because you don't really need it for this laparoscopic surgery. This is not open surgery. So Prospect even has guidelines for cesarean section. So they do mention what we are practicing most of the time. Okay, you use IT morphine, 50 to 100 mic. If not, you can use epidural morphine, 2 to 3 mg. But if you don't use intrathecal morphine, if you're not giving spinal morphine, epidural morphine, then they do suggest adding a block, such as a TAP, and interestingly, QL, because not many other guidelines recommend QL. It's quite new. So the Prospect cesarean section do mention that you can consider QL. And they actually even mention ESP for cesarean section. This was interesting. There were 2 studies which showed ESP is actually better than TAP. The idea is ESP will block somatic and visceral pain, but this is under debate. There was a reply letter by Prof. Manoj Kamarkar and team saying that ESP shouldn't work, and they don't recommend you put the ESP in the guidelines. And then there was a reply from the Prospect team as well that there is enough evidence to support it, and they believe in it. So debatable there, but you can always do a TAP, you can do a QL. You don't have to do an ESP if you think it might or might not work. You have other options. Okay, so in summary, I know I covered a lot of types of surgeries. It might be a bit confusing, but in summary, for abdominal and pelvic surgery, TA is still the first choice because it's been around the longest. It's been proven the most studies and all that. TAP block is the next because it's the most oldest of the fascial plane block, so it has the most evidence as well. There are newer techniques, of course, such as a QL and lumbar ESP, but they don't have enough evidence to routinely recommend it. So just a brief mention on TAP block. I think most of you have seen or performed one before. It's great because it's opioid sparing. It's also great because patients they can walk around. It's not like a epidural or spinal. So the idea, of course, is you're going to block the intercostal nerve. So there's a few types of TAP block, just for you to be aware. So there's a subcostal, lateral, and posterior, anterior. They all block different parts of the abdomen. So before you do the TAP block, you should decide where you want the block to cover before you perform. So just quickly, this is the different TAP blocks you can do. Okay, so that is the classic or the lateral. This is the posterior, anterior, and that is the subcostal. The newer blocks, QL and lumbar ESP. So QL also has a few types, QL1 and QL2 and 3, or QL3 is also known as transmuscular. So you can see they have different coverage. So again, very quickly, QL1 and 2, you are giving it anterior or lateral to the QL muscle, whereas QL3, you're giving it transmuscular, so you give it anterior to the QL muscle here, between the psoas and the QL. But I want to bring attention to one relatively new block. It's called the EOI block. So you might be sick of hearing blocks now, but just bear with me. This is a good block because it's quite easy to do. It's very superficial. You do it over the ribs there. So we in UCAM recently published a case report where we put catheter, and now we're starting to do it quite often, catheters for this Whipple surgery, hepatectomies, open colis, and so on. So it covers that region of the abdomen. So why is it so good? It's very easy to see. There is a bone at the back, unlike the subcostal tab. So there's a safety margin. It's easy to put a catheter because it's close to where the ribs is. The muscles there are quite tightly compact. There's no fighting for real estate. That means surgeon's incision is there. You're not going anywhere near the incision like a subcostal tab. And you don't have an issue with anticoagulation. So this block is gaining popularity. Now I'm just going to cover a few more things which are mentioned in the ERAS guidelines. So for open abdominal aortic surgery, they recommend epidural analgesia. For peripheral vascular surgery, we know blocks are very good. They improve the outcome. They have great outcomes for amputation. They have great outcomes for AV fistula insertion. More likely, the fistula surgery is going to be successful, and also the long-term survival of fistula if the block is done without the block line, instead of like a general anesthesia. Okay, so this is the last part of my talk. So I want to talk about ambulatory spinal anesthesia. There are a lot of advantages of doing spinal anesthesia in the daycare setting. So these are them. There are also disadvantages to consider, especially when you use a long-acting spinal anesthetic. So now there are guidelines like this out there, which say that if you want to use spinal for daycare, something you can consider is hyperbaric prelocaine, which has a much shorter duration, 90 minutes. And there are already evidence out there. RCT is comparing hyperbaric prelocaine to bupi. So shorter time to onset of block, shorter time to regression of block, shorter time to the patient passing urine, shorter time to discharge readiness, and whether it's safe, because lignocaine, there was this talk about TNS. So they've looked at a bunch of patients so far and seen the incidence of TNS is actually quite low, okay, which is even lower than spinal lignocaine, so it's quite safe. And this is just a bunch of people doing hyperbaric prelocaine for cesarean section. So this was interesting. And what they found was shorter motor block, shorter PACU stay. Patients were happy. So you don't have, you're concerned the prelocaine is going to wear off, patient will be pain, but satisfaction was equal. Obstetricians are happy. No difference in maternal or neonatal effect. So it's something we can look towards the future using prelocaine for cesarean section. So the last few considerations is, remember your blocks as a single shot only lasts about 8 to 14 hours. You can prolong by another 4 if you add dexamethasone or Presidex. So this is something you need to consider. When you don't do a block, patient will be in pain at the start. Pain score is about 8, and then it comes down. When you do a block, this happens. Initially, pain score is low, pain 2. But at about the time when the block wears off, you'll have rebound pain. And this can be a problem because it could be potentially, of course, other than having severe pain, there might be long-term implications we don't know, like chronic pain. So if you add a block, single shot block, you should combine it with multimodal analgesia to reduce the peak or the rebound pain. Even better if you use a catheter, which can completely eliminate the peak or the rebound pain. So to summarize again, we're talking about RA in the era of ERAS. So I can conclude that the current implementation of RA in ERAS is still very limited because there are many different techniques. So it's hard to do studies. It's hard to do high quality studies. Advancement in ultrasound, refinement of techniques. You now have a lot of new techniques focusing on the distal nerves, such as the PANG, such as the IPAC, and so on. So they're likely to be adopted into ERAS protocols in the future. RA, when tailored to individual patients and surgical procedures and used as part of multiple analgesia, will enhance the benefits of the ERAS pathways. So we need to help integrate RA into ERAS protocols to make sure the benefits of ERAS are met. So just as a reminder, these are the benefits of ERAS. So everybody wins if we do it together. Thank you.